So thank you, my students. We will continue our lesson, especially discussion on university question on endocrine disease, and then we will discuss some question about the blood disease. And in the last class, we have discussed 5 questions about the endocrine disease, and today we will discuss another two question over the endocrine disease. And our first question on endocrine disease is 50 years female, diabetic for 5 years, came to outpatient department for follow-up. 50 years female, diabetic for 5 years, came to outpatient department for follow-up. So what history will take and what clinical examination we will do for assessment of the patient. So regarding history, we will ask the status of diabetes mellitus from history, whether the patient is suffering from polyuria or not, the patient has got polydipsia or not, and whether the patient has polyphagia or not. If this polyuria, polydipsia, and polyphagia is not present or controlled, then we can think that the patient is clinically diabetes is controlled. And next, weight loss. For diabetic patient, weight loss is a common symptom, so we should ask the patient. Blurring of vision. If there is any complication of diabetes mellitus, especially diabetic cataract or diabetic retinopathy, then the patient have blurring of vision. We can ask tingling and numbness and burning sensation in hands and feet, which indicates that the patient may suffer from diabetic neuropathy, and puffy face as in case of diabetic nephropathy. And what anti-diabetic drug patient is now taking, that is a good history. If the patient is on insulin, then we will consider the patient and may have some complications. If patient is on oral drugs or no drugs, then the patient is going to be controlled. And next thing is your clinical examination. We will see whether the patient is dehydrated and whether the patient has got tachycardia. In case of diabetic neuropathy, especially autonomic neuropathy, and blood pressure to detect postural hypertension, which also occurs in diabetic autonomic neuropathy, and edema can develop as a macrovascular complication of diabetes mellitus due to CCF and also due to insulin therapy. So these are the points to be examined clinically. And in nervous system examination, patient cranial nerves, especially third cranial nerve, seventh cranial nerve, even fourth and sixth also can be examined. And motor examination, deep reflex of the lower limbs will be decreased in case of motor neuropathy, and plantar extensor in diabetic motor neuropathy can occur. Sensory loss, especially the sense of vibration, which is first lost, then other sensation, position sense, touch, pain also impaired in diabetic neuropathy. And now, second question was, what are the mention the investigation for assessment of microvascular complication. And microvascular complication, one is your diabetic nephropathy. So we can detect 24-hour urinary protein. If proteinuria 130 milligram or less than 300 milligram, that indicates microalbuminuria. And if more than 300 milligram, it indicates macroalbuminuria. And serum creatinine in this aspect we can do to detect uh, CKD that may occurs in diabetic neuropathy, nephropathy. And diabetic neuropathy, nerve conduction velocity can be done, which is decreased. And for diabetic retinopathy, ophthalmoscopy uh, can be done, and we can see microaneurysm, dots and blood hemorrhage, hard exudates, new vessel formation, retinal detachment, which can be detected by ophthalmoscopy. Third question, name two secretox and their side effects. Secretox are the drugs which increases insulin secretion from the beta cell, and sulfonylurea is the secretox, and the commonly used sulfonylurea nowadays is glyclazide and glimepiride. And their side effects, it can produce weight gain and hypoglycemia. So this is about the question number 6. Question number 7. A 65 years old man was brought to hospital with altered consciousness. His blood glucose was 45 millimole. Blood glucose was 45 millimole per liter and sodium was 150 millimole per liter, and no ketone body in urine. So what is your provisional diagnosis? Our provisional diagnosis is non-ketotic hyperosmolar diabetic coma. Non-ketotic hyperosmolar diabetic coma. And our second question is your what history and clinical examination will you do for assessment of the patient? From history, we can ask the patient regarding fever. So fever occurred due to infection, and the patient may have history of MI, which can aggravate these features. Stroke can also aggravate these features. Those who taking steroid, they have these features very commonly. So this history should be taken. And on examination, as patient is unconscious, so GCS should be done. GCS should be done. Blood pressure, the patient may have hypotension. Temperature, the patient may have hypothermia. Pulse, both tachycardia and bradycardia can occur. Unilateral leg swelling occasionally can be seen due to DBT. Now, the additional investigation for this patient, Plasma osmolality should be done. Serum urea, which is increased, serum potassium also increased in this patient. Now treatment. A specific treatment, injection soluble insulin 50 units in 50 ml normal saline and through insulin pump 3 units per hour and infusion 0.45% sodium chloride, 3 liters IV over 12 hours, and fluid required fluid is replaced within next 12 hours. Injection enoxaparin 40 milligrams subcutaneously twice daily to prevent DVT and ceftriaxone for infection. Other general measures, catheterization, intake output chart, maintain nutrition. So this is the question number 7. Now we'll discuss on question of blood disease. Our first question of blood disease is a 45 years male admitted with severe anemia without organomegaly and his blood count is 2000 and platelet count is 40,000, ESR 115 millimeter. What is your most likely diagnosis? Our most likely diagnosis is aplastic anemia, and write one investigation to confirm the diagnosis with possible findings. One important investigation is bone marrow aspiration and study, and findings is hypoplasia or aplasia of the bone marrow. And third question is write down the treatment plan. Treatment plan, general measures, blood transfusion to correct anemia, and IV broad spectrum antibiotics, especially injection ceftriaxone to combat infection. And a specific treatment is IV antithymocyte globulin and immunomodulating drugs like cyclosporine. And newer treatment is bone marrow transplantation, especially homologous stem cell transplantation. Now question number 2. A 19 years male presented with fever, purpura, bony tenderness and generalized lymphadenopathy. What is your clinical diagnosis? Our clinical diagnosis is ALL, acute lymphatic leukemia. Question number 2, write down the investigation of this patient. The investigations are WBC, maybe very low up to 1000 or very high up to 5 lakhs, and average count is more than 1 lakh per cubic millimeter of blood. Hemoglobin count is reduced, platelet count also reduced, and peripheral blood film shows atypical WBC, lymphoblast more than 30%. Second investigation, that is confirmatory investigation, is bone marrow aspiration and bone marrow study. Marrow is hypercellular, myeloid erythroid ratio is changed. Plenty lymphoblast and RBC and WBC series cells are replaced by blast cell. Now, how will you treat this patient? And first of all, general measures, blood transfusion to combat anemia and thrombocytopenia, and to combat infection we can give broad spectrum antibiotics. And second, and specific treatment and is remission induction. For remission induction, we can give injection vincristine, injection daunorubicin, injection intrathecal methotrexate, and prednisolone. And for remission consolidation, we usually give injection vincristine, injection daunorubicin, and injection cytarabine, and injection MTX IV. And for remission maintenance, again injection vincristine, MTX, not injection. Here orally MTX and prednisolone should be given. A newer treatment for ALL is bone marrow transplantation, homologous stem cell transplantation. Now question number 3. A 65 years old male presented with severe generalized body ache with bony tenderness, fever for 3 months. He is severely anemic and has no organomegaly. X-ray shows multiple osteolytic lesion. What is your diagnosis? Our diagnosis is multiple myeloma. Next question was, write down the investigation of this patient. Regarding investigation, blood ESR is markedly raised. Calcium, serum calcium level also increased, and immunoelectrophoresis of the blood will show myeloma protein or M protein in blood. Serum creatinine and may be high in case of CKD. Urine and test. Urine, from urine we can detect Bence-Jones protein, and X-ray skull we can see multiple osteolytic lesion, and in bone marrow study we show malignant plasma cell. So these are the investigation for multiple myeloma. And for treatment, general measures for analgesic purpose, paracetamol, and for hypercalcemia, plenty of water intake and bisphosphonates should be given, antibiotics for UTI, blood transfusion to correct anemia, and if pain is not relieved by paracetamol, then thalidomide and local radiotherapy can be given. Specific treatment, thalidomide, which acts as anti-tumor agent. Melphalan is again drug of choice for multiple myeloma. It is a alkylating agent. Prednisolone, immunomodulating drugs, and bortezomib. It is the recent drug for multiple myeloma. Another newer treatment is bone marrow transplantation, especially homologous stem cell transplantation. So this is the treatment of multiple myeloma. Our next question. A 20-year girl having gum bleeding and few purpuric spots on lips following upper respiratory tract infection 2 weeks ago. She is a febrile, no organomegaly, no lymphadenopathy, no bony tenderness. What is your provisional diagnosis? Diagnosis is ITP, idiopathic thrombocytopenic purpura. Next, write down the investigation of this disease. Platelet count is markedly reduced, hemoglobin and WBC normal, and bone marrow shows increased megakaryocytes. Treatment. Treatment and is started with prednisolone 1 milligram per kg per day, and it is usually given if there is spontaneous bleeding. And second drug is IV immunoglobulin. Indication to raise platelet count. And third drug is platelet transfusion, and it is given when life-threatening bleeding occurs. And splenectomy done when recurrent bleeding occurs. And low-dose prednisolone, if there is still bleeding, then low dose of prednisolone given. Tablet cyclosporin, it is immunomodulating drugs that can be used when prednisolone fails to control bleeding. So this is the treatment modalities of ITP. Our next question. A 20 years boy presented with painless, rubbery, discrete cervical lymphadenopathy arouses the suspicion of Hodgkin's lymphoma. And what investigation will you advise for staging and to verify the disease? For diagnostic purpose, lymph node biopsy should be done, and we will get Reed Sternberg cell, multinucleated giant cell, cell strip of Hodgkin's lymphoma. And for staging purpose, we can do some investigation, X-ray chest to see the mediastinal involvement, ultrasonography whole abdomen to see abdominal lymph node, spleen and liver involvement, and CT scan of the abdomen also detect spleen, liver and abdominal lymph node involvement, and bone marrow study to detect bone marrow involvement. And staging is done if in stage 1 when single group of lymph node is affected, in stage 2 more than one group of lymph nodes is affected, and stage 3 more than one group and above and below the diaphragm, and stage 4 when diffuse involvement of the tumor, especially bone marrow and liver is involved. And A symptom, no fever and no weight loss. B symptom, fever and 10% weight loss. Now treatment modalities. Radiotherapy. Radiotherapy is given in stage 1A and stage 2A disease, and chemotherapy is given in stage 3 and 4 disease and all B symptoms patients. Now 4 chemotherapeutic agents used in Hodgkin's lymphoma. One is doxorubicin, second is bleomycin, third is your vincristine, and fourth is dacarbazine. So these 4 drugs are commonly used in Hodgkin's lymphoma. Now question number 6. A 30 years female presented with sudden swelling of her right calf and inability to move. What is your probable diagnosis? Our probable diagnosis is DVT, deep vein thrombosis. Our next question, what are the differential diagnoses of this patient? Cellulitis, filariasis, and ruptured Becker's cyst. Becker's cyst. And investigation for DVT, duplex ultrasonography of the leg vein shows thrombus. D-dimer is also increased, and contrast venography confirm the diagnosis. And question number 4, what is the treatment for DVT? Other investigation for cellulitis, WBC count will be increased. For filariasis, eosinophilia we will get ICT for filarial antigen positive and PCR for filarial DNA also positive. And for treatment of DVT, injection enoxaparin 40 to 60 milligrams subcutaneously twice daily for 5 days, then tablet warfarin 5 mg daily till INR 2 to 3. And general measures, elevation of the limb. So this is the end of question number 6. And this is, I think, the last question of today's discussion. A 10 years boy having history of repeated blood transfusion for anemia, one of his two sisters suffering from similar disease, and his parents are consanguiniously related. What is your probable diagnosis and what type of inheritance it is? The diagnosis is congenital hemolytic anemia, especially thalassemia, and type of inheritance is autosomal recessive disorder. And what are the characters of autosomal recessive disorder? Male and female are equally affected. Disease expressed in homozygous parents, and 50% offspring will be carrier, 25% normal, and 25% affected. Now, 4 other diseases of autosomal recessive disorder: cystic fibrosis, Wilson's disease, thalassemia, and hemochromatosis. So I think this is the end of today's class, and and today we have finished, first of all, respiratory system, then cardiovascular system, then infectious disease, fourth endocrine, and fifth blood. These 5 systems we have completed, and in the next class we will discuss regarding the rheumatology, rheumatological disease, and then question over other systems will be discussed. So lastly, I thank my students who, in spite of their different difficulties, attended the classes, and I pray to Almighty God again to save them, save their life, and make their life happy so that they can continue their study. So thank you all.